Hi, welcome along to our final PF chat for the month of September. I'm delighted to be joined today by Dr. Naftali Kaminski, who is the Chief of Pulmonary Critical Care and Sleep Medicine in Yale School of Medicine. Welcome, Naftali.
Well, thank you. Welcome. Thanks for inviting me. Yeah.
No, thank you for being here. So maybe for those that don't know you, could you give a brief introduction to, what you do and, how you've got to where you are in Yale today?
Yes, I'm a pulmonary physician by training. I was born and raised in Israel, did my clinical training and actually a long time of clinical work in Israel, and then started being restless and went to train with Dean Shepherd at UCSF. Trained really in heavy-duty basic science research. But towards the end of my fellowship, there was the emergence of genomic technologies. And I said, well, if we could analyze human tissue, if we could take an IPF lung, a fibrotic lung, and see what's actually in it. Because before that, most of the research we did was we would generate a hypothesis based on science that we thought we knew and the mouse tools that we had available. So I really like this idea of inversion, analyzing human tissues. At the time, it was extremely unpopular, and some people raised an eyebrow. It was actually very hard to get a few lungs. It requires a significant effort. But we actually did it, and this was the first time that people analyzed the whole genome of human lungs with pulmonary fibrosis. I published this in 2002, and that launched my career. One of the things that happened to me after being in UCSF, my plan was to stay in Israel, and I returned to Israel for 2 years. And then I was recruited by Augustine Choi to start the Simmons Center for Interstitial Lung Disease. And this is actually the way that my career has gone, which is, in some ways, it was driven by patient initiative. In this case, it was a very wealthy person, Richard Simmons, whose wife died of pulmonary fibrosis, and he wanted to change the field. He didn't want the center like all the others. And I was a good fit because I did human research and I did genomics. And so I came to Pittsburgh in 2002 as the director of the Simmons Center, got to know amazing people like Kevin Gibson and Jim Dauber and Kathy Lindell. And in some ways, the rest is history because the Simmons Center was a unique model of integrated clinical care research and education about interstitial lung diseases with a very strong focus on the community, patient involvement. We had the first support group. Kathy, as you probably all know, is an amazing advocate for patients. We created one of the largest databases. At the time, it was the largest database, definitely as a single center, it was the largest database, and got a lot of NIH funding, did a lot of patient advocacy events, got involved. I think we did the first state registry in the country. And my career kept up. And over the years, we've discovered both novel mechanisms for pulmonary fibrosis and novel biomarkers. In 2013, actually 2012, I was approached by Jack Elias, who was the chair of medicine at Yale, and offered the job of being the chief of pulmonary critical care and sleep medicine in Yale. I was really excited to join Yale. It's a top 10 medical school and university. And I also like the opportunity to work with a huge hospital, Yale New Haven Hospital, and to be involved in the education of future scientists. And it's been amazingly good. I didn't have to give up my research. Our work has gone even better. We doubled our NIH funding. So at an age that everybody else is playing defense, we play offense. Our clinical programs have increased. We have an amazing interstitial lung disease programs and others, and we're now looking at creating transplant. So that's how I landed at Yale. I get a little bit, I'm less focused than other people. So I get a little bit bored or restless if I don't do a lot of things. And I think that's been a guiding principle for me at Yale. I'm involved, from research and educational fellows and thinking about clinical program to actually physician wellness, faculty engagement, and definitely this thing that for me has become a very strong driving force in the last 5 years or 10 years, which is really bringing in the patients into the community. I've benefited a lot from just patients who told me what they thought. I have patient friends on Facebook, patients follow me on Twitter. We have personal interactions. One of the patients that many of you know, Diane Reichert, was a good example. She was never one of our patients, but she had this idea of creating the IPF Awareness Blue for IPF event. We were basically friends on Twitter and Facebook and became friends in real life. We brought her to Yale to do a opening of an academic years. This is still going on, sadly, Diane passed away. Her words were an inspiration. And today, some other IPF advocates like John Mortanus or Charlotte Saunders, these are people that I consider not only my friends, they are in some ways role models and inspiration because they push for something which is very important and I believe is achievable, which is not only slowing down pulmonary fibrosis, but actually reversing it. So hopefully that's a good summary.
It's a great summary. Thank you very much for that. So thinking about kind of where progress has been made in understanding pulmonary fibrosis, where do you think the next advances are coming in terms of understanding the genetics? So there's a lot more understood today in terms of familial IPF, and where do you think things are going in terms of better diagnosis and further advances in potentially slowing down the disease and even potentially reversing it, like you mentioned?
So when you look about the history of pulmonary fibrosis or idiopathic pulmonary fibrosis, and I wasn't there from the beginning, I've been in this field for 16 years or 17 years, but you see a big shift in the last 2 decades. So you may say that the first decade of the 21st century, in some ways, was shifting to the human samples. So we moved from hypotheses generated based on our understanding of other fields of disease or mouse-related research, which is good and helpful, but limited, to actually observations obtained in humans. And my group was focused mostly on analyzing of human lung and identifying the molecular pathways there. Other groups have been focusing on patients' blood and, for instance, genetics. And together, these approaches created a completely different paradigm of pulmonary fibrosis, because nowadays we have this view. We used to think that pulmonary fibrosis was this strange inflammatory event that happened to you, and then you develop fibrosis. We gave patients immunosuppression, which we now know was detrimental to them. Now we have a much better integrated model of the disease. What I find amazing is how reproducible research in pulmonary fibrosis has been. You all hear, about some things like nutritional science. Physicians tell you today one thing, and then 5 years later it's changing. Actually, many of our observations in the first 10 years of the 21st century have been now repeatedly replicated. So what does it mean? We know now that probably 2 to 5% of the patients with pulmonary fibrosis, what used to be called idiopathic pulmonary fibrosis, have a real genetic disorder. It runs in the families. It behaves like what physicians call a Mendelian disorder, really clear inheritance. It's not completely deterministic, so it does mean that if you have it in your family, you're going to have it, but there's a higher risk. And the genetic testing, although it's not available enough, is actually important. The second thing that we know is at least 30 to 50% of other patients with pulmonary fibrosis have a genetic predisposition. And this also has been now replicated in numerous studies. So if you think about diseases that are like pulmonary fibrosis, like diabetes or coronary heart disease, diseases that are complex, most of them are not as genetic. So there's something very special about this disease. And in some ways, I would argue, you know, the term idiopathic, the I that we put in IPF, means that we don't know what is the cause. I would argue that for us, IPF is less idiopathic than diabetes or coronary heart disease, because in many patients, it's the genetics. And I'll go back to this in a second because it allows us to put a model of the disease together. The third thing I think that we have a better understanding is that there is a strong contribution of the environment. Many other conditions cause pulmonary fibrosis. Hypersensitivity pneumonitis is one of them. Exposure to dust, potentially air pollution. We definitely know that air pollution exacerbates and makes pulmonary fibrosis worse. So, of course, smoking increases the risk of pulmonary fibrosis, but not like other diseases. So we can sort of know, we have now a model in which if you get injured and you have a genetic predisposition, there's a higher risk of getting the disease. Now, we've learned over the last few years that there are several important mechanisms. One is a lot of the genes that are related to pulmonary fibrosis, that are associated with pulmonary fibrosis, are genes that related to what we call aging mechanisms. So when I say aging again, we don't mean, you know, the simple chronological aging. It is the way that the body or the organism senses its age. So you can be 80-year-old and be biologically 50-year-old or 60. You can also be 60-year-old and be biologically 80-year-old. That's also, especially if you smoke a lot or drink a lot. But what is interesting in the patients of IPF, they're usually not they're relatively healthy people, regular people, but it seems like some parts of their lungs or some cells in their lungs age a little bit faster or disproportionately. And the data from the analysis, the genetics, there's a molecule called there's a region in your genome, in every cell in your body, that's called the telomere. The telomere is like the rings in a tree. It tells you your age, your biological age. And there's a whole machinery that fixes the telomere. Our cells don't want to age. So they actually have, in every cell, there is some little engine that says, okay, I'm going to try to get the clock to wind it back, right? I'm not aging this fast. And in many patients with pulmonary fibrosis, have a defect in this mechanism. It's almost like this little engineer that's supposed to keep it always at 4:45 instead of 5, is not working well. Now, this is important because it starts to explain what is happening in pulmonary fibrosis, why some cells in the lung are completely abnormal. But it also suggests that there may be strategies to attack these pathways. You know, when you're trying to fix something and you don't know where to start. Because the fibrotic lung, one of the first things that I saw when I analyzed a human pulmonary fibrosis lung is that it was a mess. It was so different from normal. There were so many molecules that were different. So you almost ask yourself, okay, where do I begin, right? And actually, some of the drugs that we use today in pulmonary fibrosis, they're not bad drugs, but they're not extremely effective. But they are effective, but not extremely. They don't reverse the disease. But what they do is they do a lot of things, right? They are not very specific. And maybe that's why they work. I think the next generation of drugs, and from the second generation, the third generation antifibrotics, will be effective in fixing specific elements of the disease. And then that's why they will bring a promise of not only slowing down the disease, but actually maybe even reversing some of the damage. The other thing that we learned from the genetic studies was potentially the importance of your defense mechanisms. So although we don't think that pulmonary fibrosis is a typical inflammatory disease, there is something in patients with IPF that suggests that they respond differently to injury and potentially to bacteria and viruses. We don't know it perfectly. Some of genetics suggest this, and also some of other research. So again, this is something that is easier to intervene, because once you identify it, you could try to fix it. And in the immune response, we have a very strong portfolio of medications that we could do. So I'll give one example, which is, from my point of view, almost in the science fiction realm. So my group was, Yale received actually a very generous donation from Three Lakes Partners to create what we call the idiopathic pulmonary fibrosis cell atlas. So as you all know, all the body is built from cells. There's billions of cells. And in the lung itself, there are 42 types of cells. When the lung becomes scarred or fibrotic, the portfolio of cells in the lung changes. So even the lung gets new cells, other cells disappear, and even the cells that remain may change. So far, we didn't have a detailed, accurate description of how the IPF cell atlas changes. So my group now is profiling thousands of cells. Our aim is to profile around either 250,000 or 500,000 cells for around from the lungs of close to 100 patients. We think that this is going to be transformative, because this will teach us not only what happens in average in the whole lung, but what are the specific anomalies that can be reversed, because then we could start having a rational discussion. In the future, I would see the approach to a patient with pulmonary fibrosis a little bit like the approach to fixing your car in some ways. So you go in, the mechanic doesn't tell you your car doesn't feel well. He tells you your battery needs fixing, your brakes need work. So in the same way, that's what we want. We want to say, okay, your transforming growth factor beta mechanism, which is the major injury mechanism or repair mechanism, is a little bit overactive. Let's tune it down. Your developmental pathways are working a little bit too much. Let's tune them down. And maybe your aging apparatus, your anti-aging needs a little bit of an upgrade. So I think, again, this sounds crazy, but I think we're much closer to it than we think. This is not something that will happen
so
in 20 years. It will happen
of targeted, personalized medicine coming to pulmonary fibrosis that's been talked about in a lot in oncology.
Right, exactly. But I think that the benefit that we have in pulmonary fibrosis, I think that many of the cells in cancer are beyond salvation. They're mutants. You just need to get rid of it, right? I think that many of the cells in the lung in pulmonary fibrosis, they could just be fine-tuned, and then they become less detrimental. But there's a lot of things that are happening now that are exciting. Now, beyond this sort of almost, well, for patients with pulmonary fibrosis, if I tell them that something is going to be available in 10 years, that's not a big consolation, right? It's helped you, it's good to know, it's good for the family and family members and others, but there's also things that are happening now. So if we look at it now, there's probably, I don't remember the number, probably 10 startups. There's numerous phase 2 trials. I thought that the last year's American Thoracic Society in May was one of the most amazing conferences I attended, because people presented 3 or 4 early stage studies that had very promising results. Rarely happens in any field, let alone pulmonary disease. And what is interesting, so we are starting to see a little bit more targeted therapies. So molecules that will normalize the function of monocytes in pulmonary fibrosis, other molecules that will potentially affect fibroblasts. We're starting to see this sort of targeting. Having said that, so we are definitely better than where we were 16 or 18 years ago. You know, I used to call, I used to say in my talks, I say 2013 was the year of IPF genetics. 2014 was the year of actually antifibrotics in medicine in general. There was no class of drugs before, and the FDA approved 2 drugs, and they were approved for IPF. Now I think we're ready for the next step, and it's basically a question: what will work first? Is it going to be the sort of the monocyte therapies? Is it going to be other molecular targets? Is it going to be the integrin inhibitors? So there's a variety of strategies that are very promising.
So you talked there about, you know, kind of maybe some new therapies coming many years down the road, and it's not much consolation to patients living with the disease now. So what are the types of things, I suppose back to linking it to the here and now, that patients discuss at support groups? What are the types of things patients can be doing to live well or live better with pulmonary fibrosis? You know, does early treatment of an exacerbation, you know, result in a better outcome, or is that something that maybe some new therapies would need in the future? You know, what are your thoughts on these types of things?
So one is my recommendation to pulmonary fibrosis patients in general, and you know, I get I actually answer every single email I get from all over the world from patients. And what I say is actually relatively the same thing. Usually these are people that read a paper and they want to be in a clinical trial from one of my molecules. So when I'm going to say it now, most of my molecules are not ready for humans. So that's going to happen probably in the next year or 2. So if you read my papers, we're working on it, but we're not there yet. What I tell patients, one is make sure that you're connected with a group that has expertise in interstitial lung diseases and pulmonary fibrosis. That's important. This is not, again, pulmonologists are amazing all over the world, but this is the disease that requires experts. It requires a multidisciplinarity. Because the diagnosis may change. You may have something that may require a different treatment, like if somebody has connective tissue disease or rheumatological disease. The other thing, look for clinical trials. Even if you're getting state of the art, there are trials now that are looking for combination therapies, or combination therapies when there is an acute exacerbation or a deterioration. Most current trial treatment protocols don't have a good solution for patients with CLL. The third is think about transplant. You know, if you are a transplant candidate, you should be evaluated at least in one center. I know that there's a huge difference in transplant access across the world, even within the US. I think Pennsylvania still does 15% of the lung transplant in the US. But
wow.
an educated patient group body should know that, right? So if you are at the stage of your life that you can undergo a transplant and you deserve one, be proactive. Support groups are critically important. One of the things that we see now is I do think that the numbers that are quoted for survival for IPF are a little bit on the low side. I think our patients live longer. And when I say our patients, I say in most of the large centers. And I think part of it is access to oxygen when you need it, support, vaccines, all the small things that medicines can do. I do think there's another thing that people underappreciate. I'm sure the patients know it, but I'm not sure that they discuss it, which is the news of getting pulmonary fibrosis are depressing. You patients hear that you have a disease that nobody knows why it happens. And it has this dire, and the therapy is sort of, who knows, right? And I think many patients, this initial shock, getting this news, causes almost a little bit depression, anxiety, potentially even almost a post-traumatic stress disorder. So I think being in support groups, being in centers that have actually a little bit psychological support, not hesitating to speak about anxiety, depression, is critical to the well-being of patients. So I really advocate being in groups and being out about it. Now, there is a lot of research in other areas that if you're in a community, you do better. So that's why I think the applications, social media is so critical. And again, and if a patient, somebody actually sent me a personal message a couple of days ago. I know the patient, but I've never met her. And said, oh, I saw this thing about some cure for IPF. And I really said that that's not a cure. But I said, I'm really grateful that you said it to me. And I think it really helps that, when patients follow sort of the key opinion leaders, and many of us are outside now, David Lederer, the editor of the Annals, Melanie Koenigshoff, many of us are out there. In the UK, Gisli Jenkins and Toby Meyer and others. I think it helps, again, I actually, if you follow me, when I see a paper I like, I sort of say, but if I have a paper that I have doubts about, I'll be polite, but I'll also express my doubts. So I think that also helps, but I think being in contact, being part of the community is critically important. We don't have yet studies to look at it prospectively. But my impression is that those patients that are able to maintain their engagement do better, and definitely for people who are candidates for transplant, maintaining well-being, weight, psychological health is critically important.
And getting evaluated for transplant early is advisable as well, because, when patients are first diagnosed, sometimes there can be an acute decline that means that early evaluation for transplant might be really important.
Well, yeah, and the other thing, of course, if you go to the large centers, you have access to therapy, to all the other things, to novel therapies. So I think it's worth. It's basically patients have to be a little bit proactive there. Luckily, we have better resource now about clinical trials, both clinicaltrial.gov, the Pulmonary Fibrosis Foundation has resources, other national groups, almost every country now. It's way better than it used to be. But it's really important. I do want to mention something I'm not sure is the other side of things, which is there is a stage in every disease and actually in every life that that interventions are unfair or futile. And I think that even on this side, it's much better to be with the centers that are experts. Because when a patient, sometimes patients call me, make an appointment, just a phone call, because they want to seek information. Actually, what they want to hear is there a way to just do symptom management? They don't want to rush anymore to the hospital. They definitely, if they don't have a real chance for survive, they prefer to potentially pass away with their kids and their families and not in an isolated intensive care unit. And it's not an easy discussion, especially if I don't know the person. But I do believe that there is a better way. And so discussing about palliative care or symptom management, it's completely legitimate. Sometimes if the patient says, you know, I've had enough. I don't think this is going anywhere, and I have my choices about my life. So I'm putting those both, in some ways, both poles. So on one side, the most aggressive treatment, transplant, you know, and the other one is palliative care. But I think they are both important components of making the life and disease course of patients with pulmonary fibrosis more manageable, more human in a sense.
And you mentioned Kathy Lindell early on. I know that's an area that she does a lot of work in as well. And I suppose kind of what you're saying is it's good that all options are discussed and to see what's best and appropriate for each individual person.
Yeah, and not to, you know, and not hesitate to seek basically help, you know. Yeah. One of the other things, so my group has focused for a few years on trying to actually understand whether we could use molecules to predict outcome. So many patients with IPF show up and they look exactly the same, but some are rapid progressors and others are going to be very stable for many years. The science behind it is extremely robust. It's very reproducible. Somehow, mostly because of industry and commercial reasons, these tests have not gone into the market. We do expect them to start showing up. But that's another thing that I think will help patients make the right decisions, because if you know that you're going to progress, exactly, you get your lung transplant evaluation and you need to move to a place that has better lung transplant programs, you just do it. If, on the other hand, you look that your profile is going to be stable, and, you know, we've had people stable for 6-8 years. You know, you focus your life on lung health and not necessarily on the acuteness of the disease. There's other things we are thinking about that, again, could be good measures of improving quality of life. I think we're very much behind in terms of taking care of cough. And this now as a symptom, not as a lead. But I think that the good thing that now it's incorporated in every single trial. So people are paying attention to it.
And I think there are people developing treatments for cough who are looking at pulmonary fibrosis as well. So, and as you say, the patient-reported outcomes have become much more important in clinical trials and in research in general as well.
And again, I really want to acknowledge that, you know, the role of patients, their families, and, you know, the advocates has been amazing. There is more funding for IPF now than there was 15 years ago. And a lot of it has been the work of these multiple groups. I think hospitals are more aware of the special needs. I think there was finally a paper that showed the benefit from pulmonary rehab in IPF. I think that's an important, again, we were a little bit behind in this field. There was no real proof. But it's, you know, some of it is basically just patients relentlessly getting involved in activities, getting engaged, signing petitions, letters. It's really, and just being out there. is important. So for instance, the wife of Israel's president has pulmonary fibrosis, and she goes publicly with her oxygen just as a way of showing that, you know, oxygen is legit. It's not something you should be embarrassed about it. It's not something that's, you know, some people think it's addictive. And I thought that this was, so she attends all the functions. She's a low-key person, but when she attends a function, even when she met with our president's wife, she was wearing, you know, her oxygen mask. So it's really important that people don't shy away from the presence of disease.
Yeah, I mean, I've been to support groups where this issue is discussed, and the alternative is to not be able to go out. For a lot of people at a certain stage in the disease, the oxygen's needed to go out and do things and try and live a normal life. So I think, you know, and these are the kinds of things that are discussed within support groups, within communities, that I think give people that confidence.
Yeah, that's true.
Well, Naftali, thank you very much for your time today and your view of the future. I think you know, I think you gave a very good snapshot for patients. You know, kind of discuss all of the options that are appropriate for you. I think it does sound that there, you know, there will be quite a few clinical trials coming up. You know, some starting next year with kind of some of the news that was coming out from ATS. And then I think for those that have the genetic link, I think you talked about the 10-year horizon. I think there'll be a lot more happening in 10 years, which is very exciting.
Yeah, I think so too. I think I'm going on a limb here, and I'm going to say that's a fixable disease. Pulmonary fibrosis. I've changed my view. I used to think that fibrosis is not reversible. I think the data we have in the last decade, and especially this complex network of molecules, it's not like your lung has become concrete and there's nothing happening. There's actually, you could almost imagine that there is a war between the good guys and the bad guys, and multiple other innocent bystanders. So you could envision that if you just change the balance, fine-tune a little bit, you could actually reverse fibrosis. And I'm not sure that this is a situation in other chronic lung diseases like emphysema, where the cells are already destroyed. So I've changed my view. I hope not to be proven wrong.
I hope you won't be proven wrong.
And that's why I created the Cure IPF hashtag, I think 3 years ago, and I think it picked up now. Yeah.
So hopefully all of the pulmonologists in the world in 10 years will be like very targeted mechanics going in, fixing particular parts, and we will be able to cure this disease.
Yeah, I share.
Thanks very much for your time, Naftali.
Yeah, thanks for inviting me. Thanks. Bye.